Dr. Medell Briggs-Malonson is a Chief Health Equity and Diversity and Inclusion for UCLA Hospital and Clinic. She is also an Associate Professor of Emergency Medicine at the David Geffen School of Medicine at UCLA. In her current role, she is responsible for the implementation and oversight of organizational structures and initiatives that promote inclusivity and equity among UCLA health staff, patients, and communities. Dr. Briggs-Malonson prides herself in building a culture of innovation, collaboration, and excellence. This has led her to become a nationally recognized healthcare improvement advisor, speaker, and best-selling author. I'd love to pass over the presentation to Briggs-Malonson.
Thank you so much, Karen. And I just want to thank all of you all for being here, and especially thank Karen and Claudia as well for the invitation. And one of the great things is that sometimes when we're a smaller group, we can actually have even more engagement. So we're all colleagues, and I am going to present a little bit about our journey here at UCLA, but feel free to stop me, ask questions. Let's make sure that we have the richness of our conversation, because I hope that we'll be able to learn from each other in this process. So I'm going to share my screen. And as Karen just mentioned, what I'm going to be speaking about is a little bit about our journey, and especially when it comes to overall data, as well as creating various different dashboards. And so the title of this slide is Advancing Health Equity Through Data Analytics and Clinical Design. And thank you, Karen, for the lovely introduction. And one of the things about me is that my other background is in quality patient safety. And when it comes to data, I felt that data is incredibly important, not only to drive change, but in order to make sure you're making the level of change that you want to impact. And so in a lot of the different health equity efforts, as well as our overall diversity, equity, and inclusion efforts when it comes to organizational performance, what I've actually tried to do with the rest of my teams here at UCLA is make sure that everything is data informed and data driven. And so now I just want to share a little bit of how we've been able to accomplish some of these different items. So when it comes to health equity, we all know that it's a key priority, and providing equitable, high quality care, it has to be the priority for we here as healthcare organizations. But we also now know, and I call it almost after the reckoning that we have had in this country in 2020, I know that many of us have actually been in the space of addressing health inequities for years, almost our entire professions. But now that people have realized, I think, a little bit more of the importance of equity, now even other external organizations and agencies are really trying to center equity and justice as much as possible, whether it's from the state and the federal government through CMS, or some of the other legislation that's coming down from the state of California, like AB 1204, or even from the federal government, such as HR 8436. But we also have some of these other entities like US News and World Report, as well as Vizient, that are really trying to capture data in order to see if healthcare institutions are providing equitable care. But one of the things that we all know on this line is that when it comes to health equity, it goes well beyond our healthcare services that we provide in our four walls. And what it's really all about is all of the various different social structural drivers of health, in which we know non-healthcare services tend to make up about 80%, if not more, of all of the various different impacts on one's overall health and well-being. And so I like to call them social structural drivers of health, which correlates with some of the different terms that you'll see in our government, because drivers tend to indicate a dynamic movement. So a driver can either improve your health significantly, or it can decrease your health significantly, versus just the term, for instance, social determinant, which tends to be a little bit more static. So the seven social structural drivers of health that all of us are focused on, and I actually added an additional one, which I like to focus on, is of course economic stability, one's ability to have a steady employment, to bring in income, education attainment, one's built neighborhood and physical environment, whether that is really looking at people that are experiencing homelessness, or we're discussing the environmental toxins that can actually be within our overall climate. Food security, we know, like there's no way that you can be healthy without having appropriate food sources and healthy choices that are at your disposal. And then community and social context, with racism and discrimination being a very key driver of one's health, not because of the color of one's skin, but because of one's potential of actually being subjected to racism or other forms of discrimination, which directly impacts their health. And then healthcare access and quality of care, which all of us, that's all of our business on the line. And then last but not least, which is really incredibly important, is technology. We live in such a digital world nowadays, and so much of the healthcare that we provide or the health services that are available are directly through some type of digital or mobile platform. So therefore, really diving in and focusing on access to devices and internet, as well as their overall technology and digital literacy of all of our diverse patient populations is key. And so that's one of the important social structural drivers that I think that all of us should really focus on. And I'll show you how we've been trying to incorporate that into some of our various different data analyses as well. So one of the things that I mentioned, and which all of us are focused on, is of course quality as well as health equity. And I think at times we tend to forget, and even sometimes our healthcare institutions forget, when we're making the important, not only moral imperative, but also the business case of the work that all of us do, they forget about the intersection between quality and health equity. So quality, as defined by the Institute of Medicine back in 2001, defined quality of care to be the degree to which healthcare services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. And in this report, that was literally released 21 years ago, they actually clearly defined what the primary foundational stones for quality of care should be. And they said that quality of care has to include, it has to be safe, it has to be timely, it has to be effective, it has to be efficient, it has to be person-centered, and it has to be equitable. This was defined 21 years ago, but for some reason, all of us really focus on timely care, safe care, efficient care, being patient or person-centered, but equity just started to be amplified over the past 2 years, although this has been one of the primary premises of this. So when we take a look at quality and then we focus on health equity, where health equity is really making sure that everyone has a fair and just opportunity to be as healthy as possible, we see the direct overlap in more ways than one, because when we add on all of those additional social structural drivers, we see that the healthcare services that we provide have to be equitable, and that's where all of the intersection comes into play. So how do we actually deploy this and actually integrate this into all of the business workings, the operations, the clinical care, the community engagement, the community advocacy that we all need to do? Well, one of the things that was our vision at UCLA Health is that we committed to be a provider in making sure that we go along the journey of providing the most equitable, high quality, culturally sensitive care to the diverse patients and communities that we serve. But we knew in order to do that, we had to accomplish certain items. We had to, number one, create robust data systems and interactive dashboards in order to ensure that the care and the experience we were providing was equitable between patient populations. But we also wanted to make sure to identify where any forms of inequities actually existed, whether it was by racial, economic status, gender identity, sexual orientation, language, faith, social economic groups, you name them, and be able to drill in on those inequities. And then from there, help to develop additional interventions, whether they're social interventions, clinical interventions. And then also when it came to community, it's oftentimes harder to capture some of those social structural drivers. So one of the things that we started to consider is how do we incorporate all of the various different vulnerability indices that are out there and published into our systems so that we can create better prediction tools and potential algorithms in order to provide greater support to patients in order to meet their unmet medical and social needs. So this is what we first started off with. And I tend to think very much in pyramids all the time. I don't know why. So I tend to think in frameworks. And so the very first thing that we said is that we have to assess for patient level inequities. And if we're going to build up these data infrastructures, let's start off with the key premise of let's get our demographic information correct. Let's make sure we're collecting self-reported race ethnicity data correctly and accurately. Let's make sure we're collecting the self-reported sexual orientation, gender identity, language, and religion, and as many other factors as we potentially can. But then from there, once we know who we're serving based off of how they self-identify, let's go ahead and start adding in all of our other social structural driver information, whether it's housing insecurity, health literacy, digital literacy, so that we have a much greater understanding of our patients, our populations, and their social situations. And then adding in the vulnerability indices, which we'll talk more about. So the social vulnerability index score, the area deprivation index score. And then once we've accomplished these 3 levels, then we should be able to have much stronger prediction tools in order to risk stratify for which patients may have more adverse outcomes or poor utilization based off of this collective comprehensive information that we've acquired. And then from there, what we can then do is really focus on truly looking at the individual unmet medical and social needs of each one of our patients and supplementing it with the appropriate care navigation, social services, health plan offerings, as well as enhanced medical care and monitoring. So that's how we thought about it from a patient level. But then we said, well, gosh, we got to do the same thing on a population level, because it's great to take care of each one of the individuals, but we need to take this also from a higher level. So how do we do that? So we took the same pyramid, but what we then did was make sure that we incorporated all of these elements so that we could see if there was any forms of inequities in clinical care, clinical outcomes, overall quality of care, utilization rates, whether it's ED utilization rates in the hospital, longer lengths of stay, whatever that may be, and experience. Because we already know that the patients that we serve oftentimes do not have the same or equitable experiences in our healthcare facilities. So we should, without a doubt, make sure that we're monitoring for that as well. And then be able to not only separate out all of this data by race, ethnicity, gender identity, sexual orientation, age, language, ability status, payer status, etc., but we also have to account for the fact that we, as individuals and our patients as well, none of us are monolithic, which means that we are all made up of a matrix of identities. So therefore, it's not appropriate just to say, well, gosh, our African-American males in the age groups of 65 to 70, they have the highest readmission rates. No, that is too general, and that can actually perpetuate stereotypes. What we need to do is be able to go deeper into that data and really drill down to see if there is a specific population based off of their matrix of identities or experiences or access that may have higher readmission rates versus just saying, well, gosh, African-American males, older, they all have higher readmission rates. So we have to assess for intersectionality of all of these various different identities in order to drill down to the most high risk or vulnerable patient populations that we're serving. So that's one of the things that we were thinking of as well. So how did we actually look at this at a higher level? So going into what type of dashboards we would need, I actually play a lot of roles since I am the chief of health equity, but I also, of course, serve as the chief of overall equity, diversity, inclusion. And I don't have a slide for how I describe that, but really focusing on strict DEI, which focuses on organizational development, performance, and equity amongst your people within your organization, is different yet related to driving health equity and justice for the patients and the communities that you serve. But they're very different practices, They're very different kind of foci in more ways than one, but they come together to supplement each other, because you cannot, in my mind, provide high quality, equitable, culturally aligned, linguistically aligned, affirming care if within your organization you have a significant amount of inequities and lack of diversity and inclusivity. So we made a group of various different dashboards. What you see in front of you are our equity metrics for inside the organization, looking at our people. Well, what we're doing now is tracking the overall diversity and representation of our recruitment, the overall diversity of our overall representation of our people at every single level of the organization. We're looking at retention rates, especially with this great resignation. Who's leaving the organization and why? And is there, what are we looking? Are we looking at voluntary termination where people are just deciding to go, or forced or involuntary termination where they're being pushed out for one reason or another? We're looking at advancement and the percentage of promotions by level and units and years of promotion, and of course, parity of performance reviews. We're looking at pay, because salary equity is a significant challenge throughout all organizations throughout this country. And then, yes, definitely looking at culture and climate. And do our people feel like our environment is inclusive, respectful? Do they have a sense of belonging? And we're looking at this across all various different demographic characteristics. Then when it comes to health equity metrics, which you're going to see, and I'm just going to focus the presentation in on this, looking at overall quality of care. So not only our publicly reported healthcare outcomes, readmissions, our patient experience, as I mentioned, but also looking at operations in terms of our rates, our length of stay, our avoidable ED visits, and then access. Are there some patients that are able to get into our system easier than others, right? And we've actually 100% have identified some opportunities for improvement. And what is the various payer mix by all of our clinical departments? Are we serving our most vulnerable populations, our most under-resourced communities the way that we should be? And if we're not, what interventions are we developing for that? So that's where all of the dashboards sort of came out into play. This is the big level view. So how do we actually start to execute this new data system and this dashboard redesign? Well, it's currently in 4 phases, which I'm going to walk you through all 4. Number 1, improving the capture and categorization of demographic and social drivers of health data, as I mentioned. Phase 2, incorporating the vulnerability indices and risk prediction tools. Phase 3, I'm going to show you a little bit of some of the interactive dashboards in order to assess for equitable quality of care and clinical outcomes. And then phase 4, I'm going to just give a couple of highlights of some of the clinical interventions we have been able to deploy secondary to this data. So the first thing that we did, we had to bring on the right stakeholders to the table. So, and when developing our new data infrastructure that's focused on equity and justice here at UCLA Health, the primary stakeholders that we brought along were actually population health, because they'd been in this work thinking about populations for a while, and definitely a critical aspect of driving overall equity amongst our communities throughout Los Angeles. We also brought together all of our IT gurus. So ours is called the Office of Health Information Analytics, and we brought together our physician informaticists, nursing informaticists, and others in order to figure out how best to develop this in more ways than one. But then we also brought in our quality improvement analytics team. So we at UCLA have a group of also informaticists that are specifically focused on quality of care, that also have a very deep invested interest in equity. Because of that, of course, there is no such thing as quality of care if it's not equitable care. So we brought in board our quality improvement analytics team. And then last but not least, my Office of Health Equity, Diversity, and Inclusion, as well as other experts in the areas of equity within the organization. So what do we do for data collection? So the first thing that we did is that we launched a brand new questionnaire in our MyChart, which is basically our patient portal. We have Epic here at UCLA. And we launched a new, what's called All About Me questionnaire. And what we did with this questionnaire, the purpose of it was to improve the collection of patient self-reported data in all those domains that I previously mentioned, in order to ensure the accuracy as well as the completeness of our Care Connect or our EPIC data in order to inform future quality and health equity initiatives. Now, if you all are like our organization, one of the things that we found in our data was that when we're looking at just even race and ethnicity data, there was a large amount of either unknown, where we didn't have the race or the ethnicity of the patients, or other. And other meaning that, yes, we have this bogus social construct, and I'm going to call it bogus because that's what it is, this race and ethnicity, because those are just social constructs that have no biologic basis whatsoever. But unfortunately, a lot of the reporting structures that we have in this country still want to collect race and ethnicity in these very static, kind of old school, antiquated ways of capturing this data to drive other analytics and monitoring processes. So of course, a lot of the other, in terms of the race category, tend to be those that identify as Latino, Latina, Latinx, who may not have classified themselves as one of the other racial groups. And so therefore they marked other or unknown. And so we kind of knew this already from being here in Los Angeles with such an incredibly rich and robust Latino population, that we were missing a lot of important data, and we weren't doing a good service to the diverse patient populations that we serve. So we knew that we needed to improve this. But also it's really important to utilize the data to improve care and experience, and then also to enhance our dashboards. So the All About Me, and this is a little bit smaller, but you all can see a bit more of this. It's an electronic questionnaire, but we also have a paper form that is translated into all of the top languages that we have here within UCLA Health. Where now that you see, because we still have constructs that we have to abide to from a regulatory standpoint, we actually just still blew out all of the various different categories. So our first question would be, how would you describe your race and or ethnicity? And therefore, you can mark as many of these categories as you like, and you'll see we built it in a cascading form. So for instance, if you identify as Hispanic, Latina, Latino, or Latinx, you have various different categories that you can actually self-identify as. But also, if you also identify, or if you identify solely as Asian, we have multiple categories that you can actually click. So we can get down to even more of how you see yourself. And we blew out all the categories for, Alaska Native or American Indian or Indigenous, Black, African American, Middle Eastern, North African, Native Hawaiian, and Pacific Islander, and even white. And in fact, we added some additional white categories even to since we last published this. And so we wanted just to make sure that it was as inclusive as possible. And we did the same thing also for language, sexual orientation, gender identity, and all of the other demographic fields. So how did that actually drive our data? Well, what we found after we deployed this is that overall 84% of our new patients engaged in this questionnaire and self-reported their data. And then 86% of our established patients, and which oftentimes we didn't even have information on them, or we had erroneous information on them, updated their data in the system. And probably one of the most important aspects of this entire initiative is that all of the various different, what we call unusable data, so where people may have classified or were classified as unknown race or ethnicity or other race or ethnicity, or is that we seen a conversion rate of 61 to 65% of unusable data now becoming usable data, and which the patients have appropriately classified themselves. And then overall, we've had about 10 to 11% of all patients decline to answer, which is totally fine, which is actually standard in our literature. And we have now been seeing upwards of about 3,000 patients complete this survey daily since we rolled this out, and even more because we're expanding to even more of our areas within the overall UCLA health system. So now we actually have much more accurate data, more reliable data, and we have less unknown data or missing data in order to make sure that we are developing our health equity initiatives on. Phase 2, socioeconomic vulnerability index scores. So as mentioned, this was really important for us too. And this really came out of our work during the pandemic and looking at COVID-19 vaccinations, which I'll show you. And so we wanted to figure out what is one of the best ways that we have at our tips of our fingers right now of actually capturing the social structural drivers that may exist in one's community so that we can account for such. And so there's three primary index scores, which I'm sure those of you on this line are complete experts in because of all the work that you're doing. We have the Social Vulnerability Index score that was developed by the CDC, which really goes over multiple different, about 15 or so different domains in order to assess social economic status, household composition, minority status and language, and housing type and transportation of a community. With the higher the Social Vulnerability Index score, meaning the more socially vulnerable a community may be. But then there's also the Area Deprivation Index score, which is also something that measures very similarly to the SBI, but doesn't actually have, although it looks like it has, it doesn't actually have some of the reliability as some of the SBI has. And then there's the Healthy Places Index score, in which, especially here in the County of Los Angeles, this was actually used extensively by the County of Los Angeles in order to really think through how we're going to provide equitable distribution of not only testing, but also COVID vaccinations. And so what we actually did during this time is that we actually said, all right, let's take all of our patients and let's just make sure that and by the way, all of these data sets are open source, free. You can just incorporate them into your EHR. Okay, so that was also something that was really important for us. But we wanted to say, what is the reliability of these index scores on the patients that we have the privilege to serve here in Los Angeles County? So my team actually did a validation study, which they took side by side, the SBI, the HPI, the Fielding School of Public Health here at UCLA created its own score, so we also wanted to see that. And then also the Area Deprivation Index score. And what we did is we said, of all the patients that we serve right now, currently, what's the availability of data on those patient populations? And what we found was that the SBI was highly reliable and captured 95.8% of all of our patients. HPI was a little bit less, 90.7%. The overall UCLA Public Health, we love them. They actually were very robust as well, but still hadn't been as validated as the CDC's SBI, of course. It was just brand new. It's like the newest kid on the block. And then also the ADI, still not as strong of a performance as the HPI or the SBI or the Fielding School of Public Health indices. So what we decided to do is like, hey, let's double down on making sure to incorporate all of them, but we're going to double down on SBI specifically within our systems. So how do we use SBI? So what we did is that we started to, as I mentioned, we wanted to create lots of interactive dashboards in areas of quality, clinical outcomes, patient experience, you name it. And now, since we had identified and we were gathering much more reliable demographic data, and now that we've done this validation study, we're like, SBI looks like the best, most validated tool that captures most of the Los Angeles area. Let's go ahead and try to see how we can incorporate them into our dashboard so we can identify any areas of inequities. So one of the things that we first started to do was our movers dashboard. So our movers dashboard is a dashboard that highlights our quality goals internally here at UCLA, and it comes out of our Department of Quality and our Quality Informatics and Analytics. And the boxes that you see here is that we added in SBI as one of the factors that we're looking at for both the overall value, overall readmissions, lengths of stay, so we can actually determine the differences or any signs of inequities between those that may live in a community that has a higher level of social vulnerability and those that may live in a community that has a lower amount of social vulnerability, so that we can visibly see where our quality metrics were tracking between people based off of the community that they lived in. And we also did the same thing for mortality, and which, yes, and I'll show you where the intersectionality of all the other demographic features, but we took the SBI and we actually started to use the quartiles and say, do we have differences in overall mortality based off of the SBI of our individual patients and our patient populations? And we continue that through lengths of stay and saying, like, where are the discrepancies? Are they all the same? Or are we seeing seeing something that we need to intervene on like yesterday. And so this has actually allowed us to be able to take a look at our patients from multiple different lenses in order to ensure that we're centering equity and centering those equitable interventions as well. But then, as I mentioned, we also wanted to make sure that we were bringing in all of the various different demographics. So what you see here is overall length of stay. And what we're looking at length of stay on this dashboard alone, you actually have our hospitals, but then you definitely also have our race, our gender, our age group, our payer status, our language, and then also a combination of gender, age, and race all simultaneously. So we wanted to say, okay, of those that may have longer lengths of stays or outliers of a length of stay, gosh, who are the patients that are making up the populations? Because that's a poor reflection on us that we're not doing something to support our patients the way that we should. And so let's drill down and see where those most vulnerable patient populations are. Same thing with readmissions as well, in which you see our readmissions here. And then as well as all-cause readmissions by both demographics as well as by SBI. And just to let you all know a little bit as well, we use Tableau as our primary kind of reporting to bring out of our data and to try to display it this way. There's a lot of different systems in order to display data, but Tableau has been the one that we've adopted. So this is a little bit more about our readmissions, again, showing the intersectionality of the various different demographics, payer status, language, as well as overall race and ethnicity, gender, age group, so that we can actually really make sure that we're providing equitable care as much as possible. So the last phase, which we are still in this phase, and I just want to make sure to underscore, we're on a journey here at UCLA in so many different ways. And although we have really dived into this data, we're still learning about the data, we're still learning about the reliability of the data, and we're still learning about how to make sure we're developing the best clinical interventions based off of this data. So I want to make sure that it's clear. In no way are we just like, oh, we have everything solved. We are truly a learning institution, and we've had many great successes. And we've also had challenges in which we're like, gosh, this is a challenge that we really need to figure out a little bit more about. But some of the clinical interventions, really incredibly proud of, is that, again, we first brought in the social vulnerability index score because we wanted to make sure from the very beginning, back during the pandemic, that we were allocating our very limited supply of vaccines in an equitable way, not only to our staff, but also directly to all of the patient populations that we serve and the communities that we could hopefully also extend vaccinations to. But we knew that kind of changed with how vaccinations were distributed. But once again, here is the overall breakdown of the social vulnerability score. And what we actually did is that we assigned points to both our staff members as well as our patients, so that we made sure to account not only for their clinical conditions, if they have a high-risk clinical condition, but also if they live in a community that has a higher level of social vulnerability, because we know that COVID, of course, completely ravaged lower income communities as well as communities of color more, and especially that overlap of low income communities of color. The SBI has a beautiful model for how to incorporate that. So we wanted to make sure that we were thinking about those who are both clinically vulnerable to COVID, but also they had higher social vulnerability simply because of the communities that they lived in. And so that's where we figured out our patient allocation scoring process, where number one, we took, this is an older model, but we took our patients, at that time was 16 and over, we applied this vaccination risk stratification model, taking their clinical risks as defined by the CDC, but then we added in our own social risk that gave the total risk, and that allowed us to rank and sort of categorize our patients for when they would be eligible to receive the vaccine, to ensure that we are providing this in the most equitable manner possible. And when comparing our vaccination rates to others, we definitely were able to vaccinate at a much earlier time those that are more socially vulnerable using this risk model versus others that did not incorporate social risk. We were able to get our vaccines out to those that were more socially vulnerable in a much more timely manner. So some of the additional clinical interventions that we've also been able to implement with our data infrastructures is really looking at readmissions reduction. One of the things that we are doing right now is when looking at readmissions, we've been able to drill down and get into those most vulnerable populations by demographic features, by payer status, and really focusing on addressing the social structural the drivers of health. And to the point that we're developing new social models that include additional navigators, additional kind of support directly in individuals' communities in order to assist them when they are discharged home. We've done some of the same work with sepsis improvement, but really looking at our sepsis care within the institution. We started to identify inequities in early recognition, treatment, and mortality. And therefore, what we've done is that now that we've actually identified those kind of settings, as well as potential patient populations, we've been able to drive additional quality improvement efforts in order to ensure that we do have equitable treatment and equitable outcomes of our patients. And then last but not least, Homeless Healthcare Collaborative. This is one of my initiatives out of my office, which is very near and dear to my heart, where we have deployed 2 mobile clinics out to the greater Los Angeles area, in which we're providing direct care to people experiencing homelessness, both primary care, urgent care, psychiatric services, and soon to be specialty care. And we're expanding our fleet to 6 vans by the fall. But the reason why this has also been so important is because we have full EHRs and Wi-Fi in our vans, because they're literally clinics on wheels. And so when we are caring for people experiencing homelessness in various different regions throughout Los Angeles County, we are able to also track the social interventions that we're performing for each one of our patients and what their additional health and medical needs are, and make sure we have interoperability with the other federally qualified health centers and the other larger health systems in the region to ensure that we're providing the most coordinated care possible. So I will stop there and see if there's any questions, any additional ideas. And thank you so much for just allowing me to share some of the work that we've been doing here at UCLA.
Thank you so much, Dr. Medell. Such valuable information. And just if anyone has questions, feel free to raise your hand or put it in the chat. Yes, Julie.
Hey, good morning. That was fantastic. Thank you so much. I do have a couple questions because we are trying to figure this out here. Obviously, we're at phase 1, just ensuring that our demographics are correct. But I'm curious about your dashboards are very complex and fantastic. I was just wondering, did your internal team build those out for you, or did you have a consultant come in for those? That's my first question. And my second question is, it seems like to be able to act on the data, you should be able to need to have data real time, right? Very quickly. And that's another struggle that we have here, is accurate data efficiently. So I'm wondering how you've worked through those 2 issues.
Yeah, thank you so much for that question. So we did build all the data dashboards ourselves. And we absolutely have them. We are able to say if we want to refresh that data each day or refresh that data each month. And I'm going to tell you, this is a significant challenge that most healthcare organizations, the challenges you're bringing up, are. And I actually sit on the Federal Health Information Technology Advisory Committee, and we are actually at the process right now of setting new standards to address exactly, as you mentioned, that EHRs, number one, they need to now start incorporating these sort of business intelligence analytic tools into the EHRs so that we can provide better care in a real-time manner, and even the dashboards themselves. So that's part of one of the contributions that I'm providing on the federal level, and we're coming out with some new standards, because what you're experiencing is what so many different organizations have experienced. And so we do build our own. We do have that real-time data, but there are, I know, some other vendors out there that have said that they can take the data, they can kind of crunch the data for you, clean the data up, and actually present it in real-time dashboards for true actionable change. But some of them vary based off the timing. So that is something that we are very fortunate to have our data analytic team, but just know that soon the federal government, and especially through the Office of the National Coordinator, we've all recognized this as a significant challenge and barrier to driving health equity.
Great, thank you. I'll leverage that.
Yes, please do. And even if you go to HITAC, if you go to, again, the ONC's website, and there's a whole section for HITAC and all the work that we're doing in terms of the importance. Actually, there's a couple other things I can use if you're trying to do leverage, because that was one thing I spoke to both Karen and Claudia about. There's sometimes in our organizations, everybody's like, okay, health equity, that's extra. We don't need to do that, right? And so I'm not necessarily immune to that here at UCLA. There's a lot of momentum, a lot of support here at UCLA without a doubt, but there's lots of competing demands. And so one of the things that I've always said, this is core, not more. This is all about us providing great care, because again, you can't have high quality care if it's not equitable, like that's defined. But the other thing that in terms of leverage, which has really gone a long way, even within my organization, for people to understand, like, no, we're in a new phase in our country and this is our obligation, is that even CMS has now come out with their required health equity initiatives, where every organization that receives CMS dollars is going to have to report on their health equity infrastructure and what they're doing with data. And so I'm happy to send over that slide, and it's really more for like hospitals right now. But so I'm happy to send over a summary of all of those CMS initiatives that are actually going into place right now during this fiscal year, but are going to be amplified in fiscal year 2023. So that's another important lever, I think, for us to all discuss with the rest of all of our leadership, of saying like, no, the government's now holding us accountable. So it's better for us to be ahead of the game versus then being penalized because we weren't investing in this and investing in our patients and our communities the way we should have been.
Right, thank you so much.
Yes, Michael.
Fantastic presentation. Probably the most comprehensive dashboard and data set that I've seen surrounding some of the DEA implementation. I think that we're probably still very early on in some of our data sets here at the VA. So we do have, similar to you guys, we do have a lot of this demographic data, not necessarily sure we're utilizing it in a more meaningful way as such as you guys. I believe that, because you mentioned that some of the equity issues, we knew about 21 years ago. So I really appreciate the paradigm shift and how we're really starting to change perception, because I believe that even though we have access to some of this data, we never necessarily put it to use, because there was the thought behind we would label certain pockets or populations of people. And so to know that we're really shifting to say that no, these much smaller tribes more comprehensively really add up to how the person demonstrates how they take care of themselves, their education and neighborhood. So really great. I'm going to take back a lot of the ideas and tips with how we can better improve and start to look at the data very differently so that we can make better decisions, healthcare decisions that cross with equity and quality. So thank you. Absolutely.
My pleasure. And if there's anything that I can help with or any insights, more than happy to do so. This is, this is all of our work. It's collective work, because we all are trying to really improve the health of all of our communities. So if there's anything that I do or my teams can do of insight, we're more than happy to do so.
Appreciate that. Thanks.
Any other questions I can answer? Any other insights or challenges? Again, Karen and Claudia and I were talking about some of the challenges that all of us face in this work. And I can say that I think a lot of the success that we've had here at UCLA has really been, and a lot of the drive came from our quality team. And I say that because with the blend of for instance, those of us that are focused on health equity, diversity, and inclusion, and with quality and patient safety, again, that's where a lot of the momentum came about. And so the Chief Medical Quality Officer here at UCLA and we've always been fully aligned with how we see these pieces. And so that was probably one of the greatest propelling focuses on how to get this work done, because our Chief Medical Quality Officer was like, we need to make sure that we are centering equity, because equity is quality and quality is equity. And my office, for instance, was only established in 2021. And we actually, so just to let you all know, like, I'm brand new out the gate in terms of my office, our work, as well as even the data. But we have been discussing this already. And again, because my background's also in quality and patient safety and patient experience, and I've always been focused on health equity before it was like a hot topic. That's how we were able to start kind of pushing it along. So if there are any challenges, I would say take it from, again, that quality perspective, because that is rooted in our organizations, like meaning our guidance organizations here in this country. It's rooted in our federal agencies, and there's not a single healthcare facility that does not want to provide high quality care. And so that marriage is one of the most important, and I think sometimes the easiest way to really start people to understand what this work is all about and invest in this work.
So what would you recommend? I'm sorry to ask another question, but what would you recommend? Because we have a very robust quality team. They do outstanding work. I'm just not sure they're at, it's core, not more right now. Mm-hmm. So how do I show value add? So, I'm sort of grassroots. I have a day job, but my sort of, passion is around this topic. How do I show value add to them without them feeling like I'm trying to tread on their turf, so to speak? Any ideas?
Yeah, I think the very first thing, which I can tell you all of my teams here at UCLA know this, is again, that Institute of Medicine report that was published in 2001 that clearly identified equity as an essential component of quality. And if you don't have those 6 tenements, then you can't have quality care. So I think that's the first thing for them to understand, because I think a lot of people in this space, they just think like, oh, this is just about, making sure that we're taking care of those who identify as racial minorities, or those that are identify or coming from under-resourced communities. No. This is about a whole lot more than that. This is about our job is providing the best care, highest quality, most equitable care to everyone, and also making sure that we see individuals for who they are and recognize the either historic transgressions that have been made upon them that has caused them to have worse health outcomes, their community or their social situation, which also impedes. And so when you take that and you say, let's think about readmissions. Who has the highest readmission rates? And we know readmissions is directly tied into payment incentives and public reporting. Well, most of the times, as we all know, normally it's those that come from more under-resourced communities and oftentimes racial minorities, right? They're not the same. That's another thing I tell in my organization. Do not ever conflate race with social economic status. They are 2 totally separate things. There may be some overlap due to all of the systemic racism we've had in our country, which has caused people of color to be disproportionately reflected in lower socioeconomic backgrounds because of truly what happened in this country. But race does not equal lower socioeconomic. If you're a racial minority, that does not mean you're low income. But when we look at readmission rates across the country, that's what we see because of all the other social structural drivers of health that we don't take into account. So therefore, when you look at that and develop both clinical social interventions that improves your readmission rates, that improves your financial bottom line, and that improves your public reporting. That's all quality and equity. Yeah, so happy to send you all that report too, so that you can have that as well. I saw some other hands, which Eileen and Rhonda, I don't know.
Yeah, thank you for the presentation. Fantastic. And like everyone has expressed, it's very comprehensive. And my question is really around historical data. I really like that you have the MyChart questionnaire integrated and for new patients, but I always wonder how you obtain accurate information from, you know, patients that are not filling out this questionnaire, those that are in, it's a huge burden. I used to be at USC and I've seen, you know, the systems and how big the endeavor is to try to clean up the data. So how do you go about addressing those that are already in the system to make sure that we are addressing patient health equity and quality of care?
Yes, I love that question. And I didn't go deep into what we're doing for our established patients, but what we did there, this is a blanket initiative. Okay. And what that means is that from April 6th, when we deployed this, it is attached to every single clinic visit. It is attached to, is now required for ED visits, for hospitalizations as well. And we're finalizing those pieces. And so it doesn't matter if you're a new patient or an established patient, the system is able to see if you've completed this questionnaire or not. And so anytime you have an encounter now, and we're finalizing the pieces. So anytime you have an encounter for UCLA Health, you will be prompted to fill out this questionnaire. Now you can say decline, I don't want to, but you will be prompted to do it. Also, what we have when you go into My Chart, like our patient portal, it's one of the first banners that's there. And it says, hey, we want to know all about you. Fill out this questionnaire. So even if you're going in to make an appointment, to check your lab, whatever it may be, then it's there. And then the last thing that we are going to do, but we're waiting till there's a couple of other initiatives we're rolling out here at UCLA Health. There will be a mass email to all of our patients about a lot of our health equity initiatives in our new patient family advisory council, because we're going to be recruiting people, and that it will also be included in that too.
Rhonda?
I just wanted to echo everyone. I think it's a great presentation. I'm so impressed with the adherence to the concept of intersectionality and how complicated human beings and human identity is. I think that's been challenging to help people understand that we are not one or two things, we are many things. And I love your questionnaire and the results you've gotten. The fact that people, when they see themselves represented, are more willing to fill out a questionnaire than when they don't see themselves represented or when they see themselves lumped in. Is there any way that you can share that slide specifically with the results that you got after expanding the categories? That was just, I think that would be a very powerful tool to use in our system.
Absolutely. More than happy to do that, because this is something that, again, everyone's grappling with. And going back to the federal government, this is something that we are explicitly talking about, how we have to do better and we have to guide all of our EHRs, the development of our EHRs, but also our facilities. So yes, because we were trying to be as inclusive as possible. And in fact, we are constantly updating it. So even recently, and I'll share this last bit because I know that Karen and Claudia are going to push me off. We are even learning so much. Like, this is all about learning. And our registration team members came to, I have a data governance, basically a health equity data governance group, came to us and they're just like, hey, we're looking at these languages and you all miss a significant language. And we're like, oh my gosh, what language did we miss? And they you miss Mixteco. And I was like, Mixteco, tell us more. So Mixteco, for those of you who don't know, because I will admit I did not know about it. It is a language that is spoken by several of the indigenous populations in Mexico, but it's not Spanish. And unfortunately, many people assume it's Spanish because people say I'm from Mexico, but it is not Spanish, and there's multiple dialects. And apparently we have been serving a lot of patients that speak Mixteco. And so they were like, can we add that? And we were just like, well, of course we could add that. But that's kind of the beauty of this. And like, it even gets the organization more, their eyes are more wide open, they're more inclusive, they want to make sure their patients are represented appropriately. So yeah, so that was just a little anecdote about the importance of inclusivity in more ways than one.
Yes, thank you so much, Dr. Medell, and everyone on this call for just sharing all the great work that's going on and being vulnerable and open about challenges. So I want to be respectful of everyone's time, but I'll be following up with, after this, with an email with an evaluation, and also with the next kind of few sessions so that you have them in mind. And then also connect with Dr. Medell about sharing any of the great information she shared today to also pass that information along. And then we'll see you, our next roundtables in August. So if anyone else has any other ideas of what you want to hear or want to share, kind of the work that's going on with you all, feel free to email me as well. And yeah, just want to thank everyone for your time. Have a great day.